Okay, let's move on to our next case. And on the screen, it tells us what the first sentence is going to sound like. History. Remember, if this was CCS, you're just going to get that first line. So we'll read through the first line together. I'll say a few things about it. Hit the pause button. Read the rest of the history on your own. Think about what you would consider important, not important, and we'll go over it together. A 62-year-old man with a history of hypertension comes to the ER with a pressure-like retrosternal pain that radiates to his neck and left arm after climbing 2 flights of stairs. Now, if this is a single best answer question, as most of step 3 is, right now I know what this guy has. And you're going to have to tell me a lot of news to get me to change my opinion. Right now I got a 62-year-old with hypertension. This guy has coronary ischemia ongoing now. You're going to have to tell me all kinds of stuff to get me to change my mind. All right? Hit the pause button. Read through the rest of it. Now, let's go through the rest of the case. 62-year-old man, history of hypertension, comes to the ER with a pressure-like retrosternal pain that radiates to his neck and left arm after climbing 2 flights of stairs. Excuse me. The pain occurred earlier today, lasted about 10 minutes, and was relieved by rest. So here's nothing to make me change my mind. This guy has coronary ischemia. He had an episode of angina, lasted 10 minutes, got better with what angina usually gets better with, either rest or nitrates. He states that this happens to him every time he climbs 1 to 2 flights of stairs and has been going on for the last 5 years. Right now, I can make a diagnosis of what this guy's had for the last 5 years. What's that? Stable exertional angina. The patient takes atenolol. What's that? It's a beta 1 or cardioselective beta blocker. He takes atenolol regularly and carries sublingual nitroglycerin for when occasional episodes of angina occur. Again, this is all consistent. It's like they cut a piece out of the textbook and are telling me what a guy with stable exertional angina will tell me. He usually takes 2 tablets of nitro as needed, and the episodes last 5 to 10 minutes. He has no pain currently. His wife insisted that he comes to the ER. Well, this guy they've just told me such a stable pattern, I can't even remember why he's coming to the ER. Well, his wife's telling him he has to come to the ER. But what does he have? He has a pressure-like retrosternal pain after climbing 2 flights of stairs. Right now, I don't have any information that this is ongoing pain. This sounds very different than that last patient who came to the ER with an hour of emergency, with an hour of chest pain. That guy had an MI. This guy has a nagging wife. I'm not sure he even needs to be in the ER. Physical exam. Vital signs. Again, let's make believe it was CCS. The only line you'll see on the screen now is vital signs 135/95, pulse of 80, respiratory rate of 14. So, again, this is consistent with a chronic stable problem. I'm not going to rush to think about thrombolytics, put in IVs, etc. All right? I have time to think about this case, and if it was CCS, do a more leisurely physical exam. The only thing he has is some mild diastolic hypertension. Yeah, sure, I'd like to fix that, but that's not important right at this minute. What's ordered on physical? Well, I think what was ordered here is reasonable for a patient like this. You might have ordered a few more parts of the exam available on CCS because you do know this patient is stable. You'll get vital signs we already know. You get the head and neck exam, which will tell you there's no jugular venous distension. What else can be pertinent here? Well, in the eye exam, I'll look for signs of chronic hypertension, but I already know he has that. I don't expect anything else in the head and neck. The carotid pulses, that's actually not part of the neck exam. That's part of the cardiovascular or vascular exam. That's not particularly relevant. There's no signs here of a TIA, transient ischemic attack. Certainly anybody with any kind of chest pain, I want to listen to the lungs, which are clear. I want to do a cardiac exam of a regular rate and rhythm. And this guy has an S4. And what is that significant for? Well, it fits in. The guy has chronic hypertension. It's probably not been that well controlled. He has a diastolic now of 95. And he has an S4. Now remember, an S4 can be transient. I could have a perfectly normal blood pressure, and if I, for some reason, get a very high systolic and diastolic blood pressure in the next 5 minutes, I'll develop an S4. What does an S4 indicate? It indicates, what's the pathophysiology? It indicates that the patient has a stiff ventricle. An S4 is a sign of a stiff or pressure overloaded ventricle, whereas an S3 is seen in patients with a volume overloaded ventricle or a dilated ventricle. So the S4 just tells me I'm dealing with a non-compliant, or in terms of diastolic function, this is diastolic dysfunction in the setting of hypertension, or an S4 can be seen with transient ischemia, because ischemia will make the ventricle stiff, and I'll develop a transient S4. Abdomen soft and untender. I could add to this, I don't feel any pulsatile masses. I'm not thinking aortic aneurysm. He doesn't have big hepatomegaly, suggests chronic right-sided heart failure. I could tell you that I'd order a vascular exam, look at the extremities, make sure there's no signs of cyanosis, make sure the distal pulses are intact, etc. But in terms of evaluating a man with stable angina, this sounds like a perfectly adequate and exam consistent with what I would expect. Now, what's our differential diagnosis? Number one is that this guy has stable exertional angina, and he's coming to the ER because his wife is panicking. Is there anything different about this episode? I haven't heard it. Okay? Now let me go back just to highlight a point I've made previously in every videotape series I've ever done, is this technique, and especially important on step 3 where the questions get longer than they are on certainly than step 1, and definitely some more information compared to step 2, is that you're going to sometimes have questions that read this long in the single best answer. And to help you focus on what you need to think about and look for, what I like to do is always read the first sentence, in this case, 62-year-old man, history of hypertension, pressure-like retrosternal pain, and it's exertional. And then what I like to do is skip to the last line where they ask me the question, which would be, which of the following would you administer? And there might be choices like amphotericin, penicillin, heparin, Coumadin, IV nitro. So I'm going to say, okay, this is going to be a question about a guy with chest pain, and they're going to have me think about the different possibilities. All right? If, on the other hand, they said choices are do not resuscitate, speak to the hospital attorney, speak to the son, fill out get the results of a health proxy, etc. I say, okay, this guy's going to have an MI, and this is going to be a medical ethics question about autonomy and end-of-life decisions. And I'll focus in on that. All right? If they gave me a guy with this kind of story and say, which antibiotic would you choose? And then I get a list of 5 antibiotics. I'll say, okay, sounds like he has angina, but I know this guy's going to end up having a pneumonia. And then you look for pneumonia clues. So it is not always very helpful, but very often it will allow you to hone your thinking, focus your thinking on what's really important in that question. And I would urge you to do that. That's not to say skip over the rest of the question. All right? Don't ever try to make a guess based upon reading those choices. Furthermore, when you scan those choices, I would do just that. I would just scan them. I wouldn't stop and think about each antibiotic or each therapy or each medical ethics decision. I just want to see what's the sort of topic for discussion in this question. Let's go on. So unstable angina, now differential diagnosis. Again, this is more for a teaching point. I don't want to be distracted by less likely items on the choices or in CCS. Start thinking about how do I treat these other diagnoses, all right? So unstable angina. Why is this not unstable angina? I haven't heard anything that makes me think it's unstable. It's not occurring at rest now. It's not happening with less exertion than it used to. It's not lasting longer than it used to. It's not being more stubborn to sublingual nitros. This sounds like a guy with stable exertional angina. Unstable angina, I want to hear something that's different in the pattern, or if it's the very first episode of a patient with ischemia, that always sort of makes me think that this is an unstable pattern. Pneumothorax we talked about earlier. Does this guy have that shortness of breath, that pleuritic chest pain? Does he have an absence of breath sounds or loss of breath sounds on one side of the lung? No, no, no. Esophageal spasm. Maybe this guy's having esophageal spasm now. But on the other hand, I was told this happened after climbing 2 flights of stairs. Gastroesophageal reflux. Well, the question has told me nothing about heartburn, nothing about indigestion, nothing about swallowing disorders, nothing about ranitidine or proton pump inhibitors. I have no reason to go and think about non-cardiac chest pain. So don't. All right? And if I'm reading single best answer, and my choices are, let's say, these first 5 that we just discussed, angina, stable, unstable angina, pneumothorax, choice D, esophageal spasm, choice E, gastroesophageal reflux, I know the answer is clearly in my mind, even before I got to reading the choices again. In fact, I scanned these after the first line And I know the answer is, halfway through that question, I know the answer is going to be stable angina pectoris. All right? And then what happens is I go back to this. I'm not going to say A, sounds right. Let me think about unstable angina and go back to the question, look for unstable pattern. Don't do that. You'll get the answer right, but you're going to spend too much time. Add 10 or 20 or 30 seconds to each question, considering the wrong choices, and you're going to run out of time. You know this patient doesn't have pneumothorax. You know it's not esophageal spasm. You know it's not GERD. Myocardial infarction, if that was one of the choices, I would have to stop and think about that one a little bit. I'd say, wait a second, it was 10 minutes of pain. The pain went away. There's nothing here to make me think that this is ongoing ischemia. So I've scanned the choices after the first sentence. I've read through the question. It's confirmed my very initial suspicion. I want to write down angina pectoris and move on, if this is single best answer. But now let's take it into the realm of CCS and how we might handle it different in the CCS setting. What would I want in this patient who's in the ER with what sounds like a stable anginal episode? What will I want as my first diagnostic test? Or, remember, it doesn't have to be a diagnostic test in CCS. CCS just says, what do you do now? All right? You got the history. You got the physical. What do you do now? Do I put an IV in? Do I give him oxygen? Do I send him to the OR? Do I send him for the cath? Do I send him for thrombolysis? Do I ask him about thrombolytic risk factors, etc.? Well, think about it in practical terms. I think this guy just had a stable anginal episode. Let me check an EKG, make sure, in fact, there aren't still persistent ST elevations. So I'm going to do an EKG. What does it show me? It shows a normal cardiogram. Is that consistent with this man having had chest pain that lasted for 10 minutes? Sure. What's the pattern of relief? I'll ask you, sir, how long have you had the pain? 10 minutes. What made it go away? Oh, I just stopped walking the stairs and I felt better. That's very different than the guy who said, I had pain for 10 minutes, I took a nitro, or I had pain for 5 minutes, I took a nitro, nothing happened. I took a second nitro, nothing happened. I took a third nitro, a fourth nitro, and finally, after 4 nitros within 5 minutes, 10 minutes after it started, it was over. That's a different pattern. All right? If this is something that got better with him just stopping from walking those stairs or just taking a single nitro, that's suggestive for a stable anginal pattern. The presence of an S4, angina, stable versus unstable, I think we've answered that already. The pattern of relief is important, and the presence of an S4. What does that tell me? It's not very specific. It doesn't help me decide between unstable angina and angina, because this guy is also hypertensive and has a diastolic of 95. So that's not a distinguishing feature. It does tell me there's a stiff ventricle. It might be because he's hypertensive and has chronic hypertension, or it might be because he's ischemic at the present moment. But again, there's nothing else here to make me think he's ischemic. Cardiogram, normal, story, stable angina. So what are we going to do to assess the patient who we think has exertional angina? So we've reassured this man. More importantly, we've reassured his nervous wife. What are we going to do in a patient who has a pattern that we think is characteristic of angina? Now, this patient, in this particular question, we've already thought about that. He's had this for 5 years, and the evaluation's probably been done. But let's talk in general, just as a teaching point. If someone comes to your office for the first time and says, a few weeks ago I thought I had a little bit of pressure, lasted a minute or two. I stopped what I was doing. I was shoveling the snow, and it went away. And then it happened again this morning. I figured I might as well get it checked out. Pain, just those 2 episodes, lasted a minute or two, stopped shoveling the snow, I was fine. Can that be ischemic? Maybe. Well, maybe I get some heartburn and indigestion too. Once I got a little pain up here after a fatty meal. So you got a lot of different possibilities there. Obviously, the first, simplest, non-invasive thing you'll do is an EKG. If the EKG shows evidence of old Q waves, then you know this guy's already had his infarct in the past, and this guy really does have coronary artery disease. So an EKG is establishing a baseline is very important. If I'm not sure after the history that this man has coronary artery disease as the cause of his chest pain, my snow shoveler, I'll do an exercise stress test for 2 reasons. Number 1, I want to establish whether with exertion that I can produce on my treadmill, he will have coronary ischemia, and I'll know that by development of symptoms, and more importantly by changes on the EKG. And just as importantly, or even sometimes more importantly, let's say I put him on the treadmill, and after 3 minutes walking at a moderate pace, he in fact does develop that mild squeezing chest pressure. I'll say, you know what, doc, this feels just like that pressure I had when I was shoveling my walk. So I'll say, okay, sounds like you have ischemia. And this is where he would stop at home. Well, how do you have him in a monitored setting now? He's hooked up to an EKG. I have a defibrillator in one corner. I have a lawyer in the other corner. I know that I have everything covered here. I'll try and push him a little bit to get an idea of how severe is his angina. If I push him and he starts working faster and faster, and he has minimal ST elevation in just say leads 2, 3, and F, the inferior wall of the myocardium, and he has no real increase in his pain, I'll say, okay, this guy has coronary ischemia. It's not very worrisome from the pattern with exercise. Let me start treating him medically. If, on the other hand, I get him up to a heart rate of 80 or 90, maybe that's what he had when he had his chest pain with shoveling snow, I say, let me push you a little bit. And he has, let's say, 1 millimeter of ST depression at that stage. I say, start moving a little faster on the treadmill. Make the treadmill go up a little bit and faster. He says, whoa, doc, that's really, maybe we should stop here. And the ST elevations are now down 5 millimeters. And then at rest, they take 20 minutes to come back up to baseline. That patient I'm really worried about, because that patient's telling me there's a lot more myocardium at risk. Increased demand, he doesn't have the supply to meet it. That patient, I might say, you know what, I could treat you medically, but you had such an impressive EKG with exercise, and at a relatively low heart rate, let's say it happened at about 95, 100, 105, a heart rate that he could get by running for the bus, taking 2 cups of coffee or whatever, I'll say, maybe I should send you straight for cardiac catheterization. Doesn't mean just because I send him for cardiac cath that the next step is going to be surgery. But certainly, I want to know the severity of the lesions if he has that impressive a stress test. So to review these 3, EKG to establish a baseline, see if there's evidence of old ischemia. Number 2, an exercise test to establish that, number 1, it is ischemic in nature. And number 2, how severe. I'll get a pretty good idea from this exercise stress test. And number 3, cardiac catheterization to directly identify the anatomy. And if I, in fact, do find a high-grade lesion in one of the 3 main coronary arteries, in a proximal portion of that coronary artery, I'll ask the coronary angiographer to do a angioplasty at the same time, and that will relieve his symptoms for the future, reduce the risk of further progression of that lesion for the time being. About 1/3 of lesions that are open with angioplasty recur within 6 months, and allow us to use fewer medications rather than have to bombard him with 3 or 4 medications for his coronary artery disease. Let's talk for another moment, for just a little bit, about exercise stress tests. Let's say I have a patient who is so out of shape that they can't get on a treadmill and do more than a quick shuffle or a slow shuffle. In other words, I can't push them because they're so fat and unmotivated. Usually it's not, in fact, a matter of unmotivated. If they're on a treadmill, they're pretty motivated. But they just can't get their heart rate up. They can't get their blood pressure up because I can't get them to really exercise. What I can do is a non-exercise stress test or for pharmacologic stress test, where I could give them a medication while they're laying on a stretcher, which they're a lot more inclined to do than exercising, and giving them something like dobutamine, which is a cardiac inotrope, increases heart rate, increases blood pressure, does the same thing as making the patient exercise, and then see what happens on the EKG. Another variant of the standard EKG exercise treadmill stress test is doing an echocardiogram during the stress test. Because in certain situations, I can't tell if the EKG is really significant, and the classic situation for that is what underlying problem on the EKG? Left bundle branch block. If a patient has a left bundle branch block before I start the exercise, then I can't read Q waves and I can't read ST changes in an accurate way. And in that case, what I'll do is I might do an exercise echo test instead of exercise EKG stress test, where while the patient is exercising, I will be looking at the wall motion of the ventricle, and if I see that at baseline everything moves nicely, and then with exercise there's either dyskinetic or hypokinetic or akinetic regions of the heart, that tells me that there is inadequate supply to that region of the heart with exercise. And that tells me that segment is ischemic. So an echocardiogram could give additional information to that of an EKG stress test. Another test that can be done with exercise is nuclear imaging, where areas that were well perfused at baseline become cold or more poorly perfused with exercise. The patient is given an injection of a radionuclear compound, typically thallium, or now there's a sestamebe nuclear compound, and the patient gets a baseline cardiac scan, and everything is well perfused, or as we say, everything is warm. And then what happens is the ischemic coronaries, the coronaries that have limited ability to increase supply because they got big plaques in them, as I exercise, what's going to happen is the better coronaries, the wide open coronaries, are going to steal blood flow because they want to dilate. They're able to dilate. They're going to steal blood flow away from my coronary with the plaque. So I get that area will become cold. There'll be less perfusion with exercise because that blood is being stolen away for the better coronaries. And that's where I can see with a thallium stress test more information than I can see with my EKG stress test. So if the EKG is equivocal, or I need some more information, or if there's an underlying left bundle branch block, a thallium stress test, besides an echo stress test, is something that is often going to give us very useful information. Now, how are we going to treat angina? All right, this brings us to a general discussion of the treatment of angina. In this patient who's in the emergency room, I'm going to restart his usual medications, which are atenolol and nitroglycerin. He's tolerated them well. Let's go back for a moment. I want to ask myself, is he getting enough of the beta blocker? How do I do that? How do I figure that out? Is he getting enough of his dose of a beta blocker? Should he get a bigger dose of atenolol? Should I double the dose of atenolol? Do I draw blood serum therapeutic level for atenolol? The answer is, you want to know if a patient's adequately beta blocked, look at the heart rate. Okay? Not the blood pressure, the heart rate. Because even if the blood pressure is well controlled, if the heart rate is above, say, 60, I know this patient can tolerate more beta blocker, as long as the blood pressure doesn't plummet. I use that as my signal, as my guide to dosing beta blockers. This guy's heart rate is 80. So not only will I restart his atenolol, but I would say, you know what, if your heart rate is persistently over 60, you can stand to have some more beta blocker, especially since you're still hypertensive. Let me get us back to our slide that we were up to. So we'll restart the beta blocker in a higher dose. I would probably double the dose here. Let's say he was on 50 milligrams of atenolol. I might go to 50 BID or 100 once a day. And I'll restart his nitroglycerin. And maybe even think about adding a long-acting nitroglycerin, either as an oral form or as a topical paste or, more commonly, transdermal form. Remember with nitrates, if you're using nitrates on a chronic basis as opposed to the PRN basis of using sublinguals, you have to be aware of the pharmacologic entity known as tolerance, which means you become tolerant to the drug and you no longer respond to it. And with nitrates, it's a function of having constant exposure to nitrates. So what you do is tell the patient, take pills during the day, don't take a dose before you go to sleep. After all, when you're sleeping, your myocardial oxygen demand is less, and you don't need the nitrates, and your body won't see nitrates 24/7. And so you're not going to develop that tolerance. Or if you're wearing a patch, take it off before you go to sleep. All right? If there's no contraindication, this man, like every man or woman with evidence of coronary ischemia, should be on an aspirin to prevent platelet aggregation on those plaques. If with a long-acting nitrate and maximal beta blockers and aspirin, he continues to have chest pain, then I'll think about adding a calcium channel blocker. If the patient is maximally beta blocked in terms of, say, his heart rate is 55 at rest, I wouldn't want to add a drug like verapamil, which tends to slow the heart rate even further. I'd be hesitant about diltiazem. In that case, I might think about using a drug in the nifedipine family, because once the patient is well beta blocked, I'm not worried about the reflex tachycardia that I'll see with nifedipine. And on the other hand, I'll get some coronary vasodilatation and some afterload reduction from this potent coronary artery and general arterial vasodilator, nifedipine. Lower serum cholesterol. We're going to try step 1 diet, step 2 diet, increases the amount of aerobic exercise if he's not having angina with his exercise. And if that fails, start him on a agent, and I'm not going to get into a whole discussion of the various agents and approach to hypercholesterolemia, but it's suffice to say that if the patient has angina, I have to be extra cautious about getting his cholesterol low, trying to maximize his HDL, trying to minimize his LDL, and trying to reduce his total cholesterol/HDL ratio. And if there are any identifiable risk factors, I'm going to try and get him to change. If he's overweight, I'll ask him to lose weight, besides the cholesterol issue. If he's sedentary, I'll try and have him do exercise in a supervised fashion so he doesn't induce ischemia. If he's a diabetic, I'm going to try and get that better controlled, etc. So, to summarize, a patient who has chest pain with stable angina as the cause, what do we need to know? If you have triple vessel disease, the only way you know that for sure is you've done an angiography, or left main coronary disease, this is best managed with a coronary artery bypass graft because it increases longevity, increases survival. Aspirin should be used in any patient with angina to reduce myocardial infarction risk, regardless of whether it's stable, unstable, myocardial infarction process. Aspirin with MI or coronary disease is good. All right? You got to tell me a good reason why a patient with coronary artery disease shouldn't get aspirin. We talked about stress testing. Number one, it'll tell us if atypical chest pain is in fact from coronary ischemia. Number two, it'll tell us if the patient is doing the stress test while on his medications, we'll get an idea of whether he is well protected. And lastly, it'll also give us the ability to detect if there are any exercise-induced arrhythmias that I need to be concerned about and the patient might have been unaware of. Okay, let's go on to our next case, another case of shortness of breath. Why are we so focused on shortness of breath and chest pain? Because, number one, they're common. Number two, they're a big cause of not only morbidity but mortality in this country. And number three, as a teaching tool, gives us an opportunity to discuss many different entities. Okay, 68-year-old female is brought to the emergency room by ambulance because of acute shortness of breath. In CCS, that's all you get. Right away I'm thinking, okay, I got to be on my toes for this CCS question. This patient is probably acute and emergent. In CCS, I'll hit next, get the screen that gives me the vital signs, see what that's about, then go on and get a full history, and then have to decide what to start to do. In a case like this, it might very well be that after I get those vital signs and after I get the history, I know she's in big trouble because maybe she has some life-threatening shortness of breath. I'm going to put oxygen on her. I'm going to put an EKG in her, even before I'll do any more of the physical. All right? Again, if this is a single best answer, and again, most of the exam is single best answer, what I would do here is that I would read that first line, skip down to the last line, and say, and read what it asks for. If the choices are do a duplex of the lower extremities, do a pulmonary angiogram, do a ventilation perfusion scan, do a chest CAT scan, do a venogram, I know this patient is going to be having a pulmonary embolus, and I want to either rule it in or rule it out, consider DVT, etc. And then I'm just focused on the issues of pulmonary embolus. If on the other hand it says do an EKG, do a stress test, do a transesophageal echo, do a VQ scan, etc., that's telling you they want me to make a diagnosis. I'm going to look for clues for that. All right? It gives you an ability to focus your thinking. Because, again, if you just look at this question, they're not looking to distract you with too much unnecessary information, but there's going to be information in there that is put there to make you think about other possibilities that are not at all relevant. All right? So focus your thinking. So, hit the pause button here, read the rest of the question, and when you're ready, hit play, and I'm going to keep talking. Okay, so you've read the question. 68-year-old female is brought to the emergency room by ambulance because of acute shortness of breath. All right, so it's probably going to be an urgent sort of issue. She has a history of multiple myocardial infarctions and is normally on a diuretic, digoxin, and captopril. What does this tell me? She has a history of multiple MIs. She has a good reason to have heart failure because she's necrosed a bunch of her left ventricle. And she's on a diuretic, digoxin, and captopril. 3 appropriate medications for heart failure, congestive heart failure. So from these total of 2 sentences, I know this is a woman with bad coronary disease. She has congestive heart failure. Furthermore, I know that her congestive heart failure, let me ask you, is it systolic dysfunction or diastolic dysfunction? She's infarcted a bunch of her ventricle. It's going to be systolic dysfunction. Okay? And is she going to have a small heart, hypertrophied heart, or a dilated heart? Dilated heart. Would I expect on cardiac exam to hear an S3 if there's a gallop, or an S4? Again, systolic dysfunction, dilated ventricle, S3, volume overload. What's the most important medication in these patients? ACE inhibition. So I'm already honed in on how to manage this patient. And again, let's say I read this question and said, what would you give this patient? And it said something like heparin, Coumadin, thrombolysis, beta blocker, or captopril, especially if ACE inhibition wasn't there. I would think ACE inhibition. All right? I would be able to answer that question based upon knowing what they're going to have me focus on. So I know a lot about this 68-year-old woman already. Over the past several days, she is normally somewhat edematous, but not dyspneic. What does that tell me? She has right-sided heart failure. There's venous congestion. Remember, there's not only forward failure and backward failure, there's left-sided failure and right-sided failure. What's the most common cause of right-sided heart failure in this country? By far, the most common cause of RV, right ventricular failure, is left ventricular failure, typically from coronary ischemia. Left ventricle becomes poorly functioning, fluid backs up into the pulmonary vasculature, the right ventricle is trying to pump into this volume overloaded and eventually pressure overloaded pulmonary vasculature, and it starts to fail, and I get the physical findings and symptoms of right-sided heart failure. Patient will complain of being swollen because it's backing up into the venous system. Patients will have on exam jugular venous distension. They'll have hepatomegaly. They might have ascites. And again, the hepatomegaly, is it a rock-hard liver? Is it a irregular liver? Is it a firm but tender liver? What does a congested liver feel like? Well, think about it. Took a liver and poured a little bit more fluid. It would be congested. It would be swollen, maybe a little tender, but firm, like a balloon that's overfilled. It's not going to be rock hard. That's metastatic. Okay? The patient will have some ascites, perhaps, not inevitably, and the patient might also have peripheral edema. Symmetric or asymmetric? Well, if it's straightforward right-sided heart failure, it will be symmetric and usually pitting. Okay. So she's usually edematous, but not dyspneic. So usually at rest, she doesn't have a lot of pulmonary congestion. Over the past several days, she has become somewhat more short of breath, and this has considerably worsened over the past several hours. So what does this sound like in context of this patient? It sounds like she has congestive heart failure, and for some reason, and we'll talk about possible reasons in a few minutes, for some reason her CHF is getting worse. And she's ended up in the emergency room because now, over the last few hours, she's acutely short of breath. So what's my most likely diagnosis? I don't even have vital signs. I don't got a physical. But what do I think is going on in this patient? Good chance she's developing acute pulmonary edema. All right? Let's look just at the vital signs, because in CCS, that's what would come up now. Afebrile, blood pressure, looks pretty good. Very tachycardic, very tachypneic. Is this consistent with congestive heart failure? Yes. Can she have a pulmonary embolus, which shouldn't be too far down on the list? The answer is sure. I mean, she has edema. She might have some venous stasis. She has congestive heart failure. So in general, the flow of blood through the venous system, everything is sort of sluggish. Can she have a pulmonary embolus? She can. She's tachycardic. She's tachypneic. I didn't hear anything about pleuritic chest pain in the history, but on physical exam, I'm going to see if there are signs of pulmonary congestion to support my strong suspicion of cardiac failure as opposed to pulmonary embolus. Is this a story of pneumonia? Ammonia? Pneumonia. No fevers, no rigors, no productive cough. I don't think so. I'm pretty firm right now that I think this patient has worsening congestive heart failure. On head and neck examination, marked jugular venous distension, chest, bilateral rales to the apices. In other words, there's fluid all the way up, both lung fields, all the way up here. Those lungs are drenched. She's drowning. She can't breathe because her alveoli, that space where she should be exchanging oxygen and carbon dioxide with her capillaries, is flooded. Okay? And an alveolus that's full of fluid is not going to exchange, get rid of its CO2, is not going to take in PO2 well. All right? And that alveolus that's filled with fluid that's coming out of the capillaries, it's going to look like blood. When she starts to bring that up, what's coming out of the alveoli? Pink, frothy type sputum. That's classic. Now, they might not be coughing and bringing up anything. They might just be wheezing and be short of breath. But if you're hearing something about a productive sputum in the setting of pulmonary edema, the classic is pink, frothy sputum. I no longer think there's any chance here of pneumonia, pulmonary embolus, pneumothorax, etc. I am convinced she has pulmonary edema here because she has an ischemic ventricle, and I don't know what tipped her over in the last few days. I would want to get some more information from her. Did she miss a couple of doses of her medication? Did she overeat, and has she been non-compliant with a salt and water-restricted diet? Those are, in fact, the two most common reasons, in addition to the possibility of ischemia. Her abdomen unremarkable, cardiac exam. She has a 3/6 systolic murmur at the apex and an S3 gallop. Let's say in addition to that, I tell you that this systolic murmur radiates from the apex to the axilla, and it's a holosystolic murmur. What does that sound like? Mitral regurgitation. If that's in fact a brand new murmur, I would wonder if she's, number one, ischemic to the area of her mitral valve, and now she has acute dysfunction of her mitral valve, or far less likely, is she actually having an acute mitral regurgitation because the valve, the chordae, have actually torn. That would be a life-threatening emergency. But so far, I don't have any reason to suspect that rare situation. Usually, it's almost always in the situation of acute ischemia. And again, I didn't hear much about chest pain in this patient. And this has been progressive over several days. The S3 gallop, as we discussed, a dilated left ventricle. Extremities confirm what we knew from history. She has lower extremity edema, and it's actually all the way up to the mid-thigh. So you could use that as a quantitative measure that she's retained a lot of fluid. Now, differential diagnosis, to my mind, there's no differential diagnosis. From this much information, you know the patient has acute pulmonary edema. And the question might ask you, what diagnostic test do you do? What therapy do you offer? If this was CCS, what do I do here? Give the patient oxygen. Put in an intravenous line and give the patient some diuretics, and we'll get to the management. But again, think about what you're going to do first. There you're going to give the patient some oxygen. Right? She's obviously hypoxic. She's tachypneic. Her rails indicate that her lungs are not functioning very well. Arrhythmia, could arrhythmia have triggered this? Well, it could have, but if I look back at her heart rate, it just says 120. Assume it's regular. She has a sinus tachycardia, probably because she's in congestive heart failure and she's hypoxic. So I don't really need to think about arrhythmia as the cause. Can she be ischemic? Yes, she can be ischemic, and that can be the cause of the acute pulmonary edema, but the more immediate problem that she's coming to me with is the shortness of breath. Does that mean I ignore the ischemia? Of course not. I need to make the ischemia better to make the shortness of breath better. But what she is presenting with now specifically are the signs and symptoms of acute pulmonary edema. Yes, of course, I want to rule out ischemia. I want to rule out acute myocardial infarction. But so far, I haven't gotten the history that makes me suspect that that's the primary etiology. Although it can. She can have silent ischemia, and the only symptom is when she develops so much ischemia that she's developing a failing left ventricle. And again, we've already discussed rupture, valvular rupture, papillary muscle rupture. You can have mitral regurgitation just by an acutely dilating ventricle. If the ventricle dilates, the mitral valve, which sat nicely in that mitral valve ring space, as the ventricle dilates, there's now a space here where blood can regurgitate from the ventricle back into the atrium. It used to fit well, the ventricle dilates, there's now a segment where blood can regurgitate. Now, what's going to be my plan in a patient with acute pulmonary edema, which at this point I'm really confident she has? In terms of diagnosis, and that's what this slide is about, we'll talk about that in a moment, we're going to go through a series of steps. But what if this was a CCS question? Would I start doing anything here? Yeah, I'm going to do something. I want to give her some oxygen. She's hypoxic. I want to fix that. Okay? Because if she's ischemic, having a better oxygen, that can only help her. All right? Let's say this isn't a CCS. This is a single best choice. You ask, what's the initial diagnostic test you will do? EKG. Is ischemia a good possibility? Sure. And if she does that, then I got to bring into operation all those things we talked about in the previous cases about management of ischemia. So I do an EKG. What does it show in this particular patient? Sinus tachycardia, Q waves and leads V2 through V4. And assume that's all the abnormalities you see. What's the next question you're going to ask? Is this an acute MI? That's what you need to know. The answer is, what are you going to ask for next? An old EKG. It turns out she was in your office a month ago and she had an identical cardiogram, and the Q waves are already there, then this isn't likely to be new infarct. This is just an old infarct, and you're seeing what she's had before. We know she's had old infarcts, and that's why getting an old cardiogram would be essential right now. I'm going to do a chest X-ray. Is it absolutely essential to do a chest X-ray here? She's not going to have anything else on the X-ray. Can she have a superimposed pneumonia? Sure. But I'm going to get an X-ray to confirm what I already know, that she's going to have cardiomegaly, she's going to have bilateral pleural effusions, which you don't always see in patients with pulmonary edema, and she's going to have cephalization and vascular redistribution, meaning the blood vessels in the heart, which are most commonly the mid and lower lung fields, I'll start to see more fullness in the upper lung fields as the vascular congestion in the lungs builds up. Will I do a blood gas? I think a blood gas is a good idea. I'm going to give her some oxygen. I want to make sure she's not hypoxic. Her blood gas is 7.48, PCO2 of 34. Let's stop and think about this in terms of an acid-base problem now. First question, acid-base disturbance. Is she alkalemic or acidemic? Obviously, 7.48. She's alkalemic. It's above 7.40, 7.42. Is it respiratory or metabolic? The second question you always ask after acidemic or alkalemic. Question number 2 in every acid-base disturbance is it metabolic or is it respiratory? Well, here, she's hyperventilating. Again, hyperventilation is not defined by tachypnea. Hyperventilation is defined strictly by a low PCO2, which she obviously has. And that's why she has a respiratory alkalosis. And she has a PO2 of 72 with 93% saturation on room air. Now, you might say, well, that's not too bad. She's over 90%, which is what I like to see my patients at. 72 is not really hypoxic, which I start to think of in terms of under 60. But if you look at this blood gas and you figure out her AA gradient, you would see that it's elevated. Because to maintain a PCO2 of 72, which after all is not great, I'd like to see her in the 90s, which would be more along the normal lines. To get that PO2 of 72, which isn't great, she got to breathe so hard that she's blowing down her PCO2 to 34. So that's telling you she's working hard to get this relatively insufficient amount of oxygen, and that's consistent with an elevated alveolar arterial gradient. So in the history, in a patient with CHF, let's review the things we've discussed. What are going to give me hints that this patient has CHF as their etiology of shortness of breath? Well, dyspnea, history of MI gives me a good reason for her to have congestive heart failure. I want to look at her drug list, meaning not only what is she supposed to be taking, but say, have you been taking all your medications? Let's say she says, you know what, it's the end of the month, I ran out of my prescriptions, I didn't have enough money to go get my new prescription until my Social Security check came in. And for the last 3-4 days, you know what? It's interesting. Since I stopped taking the medication, that's about when I started getting the symptoms. All right? So non-compliance with medications, whether known or unknown. Some of these patients are on a dozen medications. They're on anginal medications. They're on CHF medications. They might be diabetic. They might have some COPD. These all run together after all. It's easy to just get confused, especially if you're elderly, maybe your cognitive function is not quite so intact. So I want to make sure that she's taking her medications. If she's not, that might be the whole answer. Get her into a system where she could be taking her medications and have them throughout the month. And furthermore, is she on the appropriate medications? Let's say a patient like this was not on ACE inhibition, then I know my first job is to get her on ACE inhibition. Besides a drug list, I also want to take a dietary history. Did someone bring over 2 pizza pies last night and a bowl of potato chips, and that's what's making her worse? If someone's a demonist, that makes me think that the patient, besides left-sided failure, has some right-sided failure. That was an important clue in this question. We just discussed diet and drug compliance. All right, what about the physical? What clues on the physical suggest that the patient has CHF, and to what extent the patient might have CHF? Obviously, heart rate, respiratory rate, and blood pressure. Patients with acute pulmonary edema, typically, because it's such a hyperadrenergic state, they're all stressed out pathophysiologically. They're hypoxic. Typically, they'll be tachycardic and hypertensive from this intense catecholamine release, from this hyperadrenergic state. So I expect them to be hypertensive. On the other hand, if she comes in normotensive, that makes me wonder, is her blood pressure lower than it usually is? And especially if she's sort of borderline low blood pressure, or certainly a low blood pressure, then I'm really worried. Because what do I call that? Low blood pressure in the setting of acute pulmonary edema, cardiogenic shock. And the mortality there is exceptionally high, right there while she's even in the ER. All right? So pay attention. The heart rate here will probably be tachycardic. If it's not tachycardic, then she's probably either beta blocked or has some conduction disturbance. Because when you have rails up to here, I would expect you to have heart rate of 100, even more. If it's not, you're either on a beta blocker or you have some problem with your conduction that you can't compensate by increasing your heart rate. Respiratory rate, of course, will be tachypneic, and the blood pressure. I expect to see it somewhat high here, and I might even have to treat it if it's real high. But if, on the other hand, it's normal or even on the low side, I'm really going to start to worry. Jugular venous distension, what is that a sign of? Right-sided heart failure. An S3 versus an S4 tells me this systolic dysfunction Most common etiology of that is ischemia, either past or present, versus an S4, diastolic dysfunction, pressure overload. Most common cause of that is, by far, hypertension. Besides hypertension, what gives a stiff ventricle? A hypertrophy, thick ventricle. In a young person with an S4 and maybe a history of syncope, especially syncope with exercise, what am I going to think of? A particular valvular disorder called IHSS, idiopathic hypertrophic subaortic stenosis, where there's hypertrophy of the ventricle, hypertrophy of the intraventricular septum in a asymmetric way, and there's outflow obstruction. That's IHSS. In an older person, let's say with a crescendo, decrescendo, systolic murmur heard at the base of the heart, what is the cause there for hypertrophy? What valvular disturbance that I just described? Aortic stenosis. Right? So in a young person who's not hypertensive with an S4, who has evidence of diastolic dysfunction, think IHSS. In an older person who's not hypertensive, think aortic stenosis. And again, most likely, after all, is going to be chronic hypertension. This patient doesn't have that picture. She has an S3, volume overloaded from ischemia. Ascites and hepatomegaly in this patient tells me not only is there a left-sided backward failure, but there's right-sided backward failure. Edema consistent with that as well. And let's talk for a moment now about the causes, many of which we've discussed. We've talked about the causes of systolic or diastolic dysfunction. There are different presentations. There are different causes. Actually, let me take that back. They don't really have different presentations. They can present, a patient with diastolic dysfunction with an ejection fraction of 80% can present identical to this patient. That patient won't have an S3, they'll have an S4. They'll typically be very hypertensive, or they'll have very severe aortic stenosis. The treatment for systolic and diastolic function is very different, and we'll talk about that in a moment. The most common cause of ischemia that we need to be concerned about in the acute setting, that we can do something about, is ischemia or infarction. The cardiogram will tell us that. It will also tell us whether the patient has an arrhythmia. If she's going, her heart rate is 180 and she has a supraventricular tachycardia, then what's the pathophysiology of her heart failure? Remember, we said she's sinus tachycardia at 120. That's expected. Let's say I look at her cardiogram. It's not 120, but now it's 180. And let's say I tell you there's no P waves. This sounds like and it's a narrow complex QRS. I think that this is a supraventricular tachycardia, and number one, it might be producing ischemia, and number two, it's such a rapid systolic function, there's no time for that ventricle to fill. All right, I need a slower heart rate to let the ventricle fill before it ejects. So at very high heart rate, your cardiac output falls because you don't have enough diastolic filling time, and that can produce congestive heart failure. On the other hand, if your heart rate in this setting is 45, you have plenty of diastolic filling time, but you just don't have enough heartbeats per minute to deliver adequate cardiac output. And then you have to wonder, why is this patient's heart rate 45? Is it overdose with beta blockers? Is it some conduction disturbance that I need to think about, even a temporary pacemaker? Again, you'll take a history about diet and medications, especially in elderly people, who might have some mild dementia, who live alone, who are poor, so they might not have enough money to choose between drugs and their groceries. These are things you have to pay attention to. And in fact, they might ask you a question. The most important management in this patient, let's say it's an elderly patient who ran out of money for her meds, is to contact a social worker and not think about giving her fancy intravenous positive inotropes. All right? Address the underlying problem. And even step 3, even though you're not out in practice, you're going to be the person who ultimately sends this patient home from the hospital. Are you going to send her home on IV dopamine and dobutamine, a patient like this, if she's poor and can't afford her medication? No, practical steps. You're going to make sure she has some financial assistance. You're going to make sure she has maybe a visiting nurse to go home with her and make sure she's taking her medications properly. Anemia, thyrotoxicosis, and pregnancy. I link these here all together because they are all in a totally different pathophysiology of heart failure, which is in fact far less common than all these other ones we mentioned, which is high output cardiac failure. In fact, the heart is not putting out a low output, it's a high output. All right? There's no problem with this heart functioning. It's functioning beautifully. The sense of cardiac failure is because even though the heart is functioning in a super sort of way, it's not enough to meet the demands in these 3 situations. So there's no primary cardiac disorder here, although if you stay in a high output state for long enough, the ventricle can't keep up eventually and will start to fail. But primarily in these settings, the problem is not so much one of ventricular systolic dysfunction for the time being. It's that you just can't keep up with your intense needs because you're so anemic. How does that affect cardiac output? Well, if with every contraction, you're only delivering one half of the red blood cells into the circulation that you'd like, you got a problem. You got to pump either twice as fast or twice as efficiently. Similarly, thyrotoxicosis, you're going to be tachycardic, you're going to have increased metabolic demands because of your hyperthyroidism. In pregnancy, you're not just pumping for one, you're pumping for two. And so you need to be aware that you need to maintain adequate cardiac output. And sometimes in a ventricle that looked okay for a woman who was functioning just fine in everyday activity, when she has to maintain the needs of a second little guy or gal inside of her, she can't meet those demands, and she'll start to develop signs of high cardiac output failure. Furthermore, aside from this, another form of congestive heart failure during pregnancy is called the postpartum cardiomyopathy. Right after a woman delivers, for reasons that are not clear, there can be a systolic dysfunction and a profound cardiac myopathy develop with profound left ventricular failure. Fortunately, very rare, but if you do get that question on the boards, again, not because it's common, because it's something you can't afford to miss, a young person without any coronary history, any risk factors, develops symptoms, signs and symptoms that in an 80-year-old, you say this is obvious congestive heart failure. But this person's 25, never been sick a day in their life. All that's happened is they just delivered a baby in the last few days. They want you to recognize the entity of postpartum cardiomyopathy. And that patient, besides treating her acutely, you should even get the cardiac transplant team involved early. Okay. What else are we going to think about in evaluating the patient with pulmonary edema, CCS? After we do the initial stabilization, what kind of things will we think about ordering? Each one of these will get you points. CPKMB or troponin. Okay, this particular patient's normal. What else might you get? Well, once you got the patient stabilized and you want to identify the underlying ventricular function and especially that mitral valve murmur you heard, you'll get an echocardiogram. How will this play out on CCS? Well, they'll first go through the whole picture, and let's say you do it extremely efficiently. You give her some oxygen, you put the IV in, you give all the IV meds that we're going to talk about in a moment. And now she's stable. She's on the floor, not even in an ICU. You got it from the ER. You got it stable so quickly and so well in the ER. You ruled that an MI, maybe even send it to a general medical floor. You don't even send it to a coronary care unit. What are you going to do in further evaluation of that patient? Remember, CCS, especially if you're efficient, might take you through 10 years of a patient's life. More typically, it's going to be a short period of time, but they might very well move you through this case in CCS to see that you know what to do once the patient is home from the hospital. While she's still in the hospital, I'll get an echocardiogram because I want to see her ventricular function. I want to see all of her valves. All right, not surprisingly, this patient has a low ejection fraction, 27%. Normal, say, about 50, 55%. Left ventricular function is not good, and she has moderate mitral regurgitation. Okay, let's talk about the treatment in the emergency room, all right, for a patient with acute pulmonary edema. And remember, CCS is not just about ordering the right things, it's in what order. Sometimes it's not terribly important whether you do drug A or drug B a few seconds apart in the wrong order, right? But sometimes they very specifically will want to see that you do things in the correct sequence. Furthermore, the majority of the test, again, is multiple choice. And they'll say, what is the single most important next step, right? And you'll have to pick in priority what is the most important. So you're going to sit the patient upright. What's the physiology that's helping you out there? You're reducing what mechanism of heart failure? You're reducing the increased preload because she's having venous stasis. She's pooling blood in her lower extremities. Less overload to the right ventricle. You'll give her oxygen. And they won't ask you, should you sit the patient upright first or give her oxygen? Because you'll be obviously doing this simultaneously in real life. But if they had to make me pick between those two, say, well, she's hypoxic. Let me fix that first. I'd give her oxygen. All right? Then I'm going to have an IV into her, and I'm going to diurese her with a loop diuretic. This is not a place for hydrochlorothiazide, chlorthalidone. This is a place for the potent loop diuretics, furosemide, bumetanide, ethacrynic acid. Typically, furosemide is the one we use most typically. And how do we give it? Do we give it orally? No. And remember, CCS will not ask you doses so far, unless they start changing the nature of CCS in the future. But they will ask you route of administration. You'll type in furosemide, and then it'll prompt you, how would you give it? And they'll give you 6 choices. Now, there's actually not 6 ways to give furosemide, but you'll type in either they'll prompt you or they'll ask you what route, and you'll type in intravenous, or you'll highlight intravenous, because you want to get fast-acting, effective furosemide. In fact, furosemide will make the patient feel better even before they've made a drop of urine, because furosemide has some venodilating properties that will help reduce preload as well. If the patient is very agitated from being hypoxic and tachycardic, morphine is very useful here, as long as they're not already hypotensive. Again, most of these patients are hypertensive. Morphine is good for 2 reasons. 1, reduces pain if they're in any. Number 2, it will reduce their anxiety, which is just increasing myocardial oxygen demand. And number 3, it has some mild venodilating properties to, again, reduce afterload. Nitrates. I'll give this patient a sublingual nitrate, tell her to chew it while I'm putting in the IV. That will be absorbed. What is the effect of nitrates in the setting of pulmonary edema? The effect that I'm looking there is the potent venodilation. It's an important effect in terms of reducing preload. And while I'm giving the sublingual nitro, I got the oxygen on her, I'm putting it in IV, and I'm going to start IV nitroglycerin as long as her blood pressure is not low. Once I have her stabilized, if she's, very few patients are so stable that they can go to the medical floor. I gave you a hypothetical situation a moment ago. She'll go to the critical care unit, the coronary care unit, especially if there's a suspicion of myocardial ischemia. It might be hard to tell. She might have had some underlying EKG changes in the past. Now she has some new T-wave changes that not that impressive, but then again are new. She'll be in a CCU. What are the other drugs that we can use in the setting of a ventricle that is an acute pulmonary edema? We tried venodilation. That's the first place we're going to go. Secondly, we could try to increase inotropic effect. And dobutamine is a potent intravenous inotropic drug. The problem with giving dobutamine, that's why it's number 7 and not number 1 or 2 on this list, is that it increases myocardial oxygen demand. And if I could get her symptoms better by reducing preload and maybe reducing afterload, I don't want to give positive inotropes if I could avoid it. I will only look for dobutamine if she's in an impending cardiogenic shock. Nitroprusside is a very, very potent afterload reducer. I would only really use it here because of its arterial vasodilation if the patient is very hypertensive in the setting of congestive heart failure. Or we now have the availability of giving an intravenous ACE inhibitor, and that's enalaprolat. And that is sometimes hard to control the blood pressure with, so it's not going to be the first thing I give the patient. We'll talk in the next slide, or in a couple of slides, about the use of a Swan-Ganz catheter placement, which will measure cardiac output and pulmonary capillary wedge pressure. And once the patient stabilized, specifically once the patient stabilized, if she's not already on digoxin, I might start thinking about digoxin. But that's the last on my list. It's a positive inotrope, which is not something I'm looking for in acute pulmonary edema unless there's cardiogenic shock, and it's below my choice of dobutamine. It's less predictable of a cardiac inotrope than is intravenous dobutamine. Okay, let's continue with our discussion of the management of pulmonary edema. We've covered it pretty well. Let's just summarize what we've just said. In terms of inotropes, what drugs are available to us? And again, don't want to use inotropes unless I really am worried about cardiogenic shock. Because inotropes, yes, it'll improve contractility, but at the cost of myocardial oxygen demand. Dobutamine will work by causing beta-adrenergic stimulation of the ventricle at the cost of tachycardia, raising the blood pressure, which is great if the blood pressure is low, not so great if the blood pressure is not low, and increasing the intrinsic contractility of the heart. Also puts the heart, since it's stimulating beta receptors, at risk of arrhythmias, tachyarrhythmias. Milrinone is a very effective drug only for short-term use, which is a phosphodiesterase inhibitor, different phosphodiesterase inhibitor than, say, theophylline, but in the family of phosphodiesterase inhibitors that increases cardiac contractility very well. In fact, it does it so well that if you give it chronically to patients with heart failure, you'll make that heart contract so well that you'll just beat the life out of that heart. And actually the survival in patients with heart failure who are on chronic milrinone or amrinone is lower than patients who don't get it. Because you're making that heart work much better, but you're just knocking it dead. Digoxin is the least efficient of the positive inotropes. It's particularly useful, and the only real time that I want to look for it in the answer choices if the patient's in atrial fibrillation. All right, that would be an ideal patient. Does digoxin convert the patient from atrial fibrillation to normal sinus rhythm? No, but it will help control the ventricular rate, the rate, by blocking the AV node, decreasing the stimulation to the ventricle from the atrium. Okay. Afterload reduction, we've discussed IV nitroprusside. We've discussed IV ACE inhibition. We've also talked about the importance and the primary importance, the most important single medication in the long-term management of a patient with systolic dysfunction, whether from ischemia or any other cause, is ACE inhibition. If a patient can't tolerate ACE inhibition because of the not so infrequent allergic cough that it induces, bronchospasm, cough, sometimes other forms of allergic drug reaction, or the patient has a renal insufficiency that makes it less desirable to use an ACE inhibitor. But more importantly, if there's an allergic reaction, I will now use an angiotensin receptor blocker, ARB, like losartan. The sartan drug family are angiotensin 1 receptor blockers, and that will be very effective at decreasing afterload by decreasing vasoconstriction and ultimately by decreasing aldosterone stimulation. Now let's talk for a few minutes, because this is step 3, and you need to know at least about the concepts of pulmonary artery catheters, also known as Swan-Ganz measurements, Swan-Ganz catheter, and pulmonary artery capillary wedge pressure measurements. When would you order one? They're not going to ask you on step 3 how to put one in, but they might ask you, is this a patient that you want a Swan-Ganz catheter? And on the exam, it will be called a pulmonary artery catheter rather than a Swan-Ganz catheter. What does a Swan-Ganz catheter or pulmonary artery catheter allow you to do? It allows you to measure basically 2 important measurements. And once you become more advanced, you could find out even more detailed information, but in a very direct, important way. It allows you to measure the cardiac output, and it allows you to measure the pressure in the left ventricle at the end of diastole. In other words, you're finishing up diastole. Mitral valve has just been wide open. The ventricle has filled. You want to know, is that ventricle overfull in a dilated ventricle? Or maybe in a patient who has hypotension, is it because it's underfilled? Now, a lot of this information you should know from your physical exam. If a patient is hypotensive and very dry, that patient doesn't have an overloaded ventricle, probably has an underfilled ventricle, and you'll give the patient fluids. On the other hand, if a patient has rails to the apices and is not hypotensive, has an S3, you know that left ventricular end diastolic pressure is high, and you'll diurese the patient. It's only in situations where there's a gray zone, or there's multiple factors going on at once. Maybe the patient is bleeding, and that's causing an MI, which is causing heart failure. Bleeding will lower the ventricular pressure. Myocardial infarction might make the ventricle ischemic. Pulmonary edema tells you that it's overfilled. Where are you in that whole combination? It's hard to know. A pulmonary artery catheter will directly measure left ventricular end diastolic pressure, and that's known as the pulmonary capillary wedge pressure. An artery is passed from the neck into the superior vena cava, right atrium, right ventricle, then into the pulmonary artery where it sits. It has a little balloon at the tip. You inflate the balloon from the outside. It then floats downstream through the pulmonary artery into the arterioles, into a capillary where it gets stuck, where it gets wedged. And at the end of diastole, on every cardiac cycle, and you get a pulmonary artery capillary wedge tracing on a monitor, and at the end of every diastole, between the pulmonary capillary and between the left ventricle, it's a constant pressure zone. There's no drop-off in pressure. It's one open channel. It's a continuous channel from pulmonary capillary to venule, pulmonary venule, to pulmonary vein, to left atrium, to left ventricle. All right? So there's no pressure drop-off. So the measurement at the end of diastole, when the mitral valve is open, the pulmonary capillary wedge pressure reflects the pressure at the end of diastole in the left ventricle. Very important measurement in terms of left ventricular filling. The patient's filling pressure and a normal capillary wedge pressure is between, say, 7 and 12. If it's 20, 22, 24, that patient's not going to get better by giving that patient volume. We just give that patient more pulmonary vascular congestion. That patient needs diuretics and venodilators. If, on the other hand, the patient is hypotensive and the patient has a capillary wedge pressure of 2, you know that patient's problem is hypovolemia. That patient you're going to give fluids, normal saline, say. So you can measure left ventricular end-diastolic pressure, and it also allows you to measure cardiac output if that is also something you need to know in a dynamic situation. For instance, if you're using dobutamine, it would be very useful to know exactly its effect on the cardiac output. An indirect measurement of dobutamine or milrinone is improvement in the patient's pulmonary congestion, improvement in the low blood pressure, but very specific measurements can be made with a pulmonary capillary wedge pressure in terms of filling pressure and a measurement of the cardiac output, which is done by the FIC, F-I-C-K, FIC thermal dilution technique, and much to your relief, on step 3, they're not going to ask you to calculate it like they do on step 1. You just need to know that the Swan-Ganz or pulmonary artery catheter allows you to directly measure and very accurately measure cardiac output. Okay, that finishes up that case of acute pulmonary edema, which allowed us to talk about left ventricular failure, systolic dysfunction, diastolic dysfunction, etiologies of heart failure, signs and symptoms of heart failure, the detailed management of heart failure, and the various medications. Let's move on now to yet another patient with shortness of breath. Okay? 35-year-old female presents to the emergency room with progressive shortness of breath. Okay? This was a single best answer question. I'm going to skip down, see what the choices are, give me an idea what this is talking about. This is CCS. I say progressive shortness of breath. Well, that can be progressive over 6 hours or over 1 week. Doesn't tell me if it's acute or chronic. I'll look at the vital signs before and the history before I can make that determination. Let's make believe that this is a single best answer question, as again most of the exam is, and put me on pause. I know by now a lot of you want to put me on permanent pause. Put me on pause, read the rest of the question, and then come back. Okay, 35-year-old female presents to the emergency room with progressive shortness of breath. It began last evening after dinner. She has a non-productive cough and pain on her right side with inspiration. All right, so right now, from that extraordinary long list of things that can cause shortness of breath, I'm already narrowing down my differential. What am I thinking? Well, began suddenly after dinner, within 24 hours, non-productive cough, pain on her right side with inspiration. So she has acute onset of shortness of breath with pleuritic chest pain and a non-productive cough. What's in my differential here? Pulmonary embolus has to be near the top of my list. Maybe a pneumothorax. Maybe a pneumonia. Pneumonia can give you all this, and it's an atypical pneumonia in that it's not productive of a cough. On the other hand, our atypical pneumonias present acutely like this. By the nature of atypical pneumonias, they're atypical, meaning they're not like your typical bacterial pneumonia, meaning it usually develops over days. It's unlike an atypical pneumonia to develop within a number of hours. My leading diagnosis already is probably going to be pulmonary embolus. Could this be asthma? Sure, it can be asthma. Maybe she had a little reflux. She refluxed a little bit into her lungs, caused a little bronchospasm. Now she has cough. And can patients with asthma have some chest pain? Yeah. Is it usually pleuritic and unilateral? No. And again, I don't remember the answer to this question, so I'm not trying to lead you someplace. I might be leading myself down the wrong track. This morning she awoke with a fever of 101 and coughed out a scant amount of blood-streaked sputum. All right, so asthma is going out the window because fever, blood-streaked sputum, not typical for asthma. Could it be an atypical pneumonia? Or maybe even a typical pneumonia. Maybe a bacterial pneumonia without productive cough. That's possible. Pulmonary embolus, which I started out as my leading diagnosis. Is that still at the top of my list? Yeah. Why should a 35-year-old have that? I don't know yet. First thing that will pop into my mind is maybe she's on oral contraceptives. Makes her hypercoagulable. That's what's going through my mind as I read through this question. All right? Why am I already so far advanced in terms of thinking of oral contraceptives, pulmonary embolus? Because I got a young woman who has acute onset pleuritic chest pain, shortness of breath. They're not usually the kind of patient who develops pulmonary emboli, so I think about what young women are often on, oral contraceptives. Blood streak sputum, not typical for asthma, not typical for pneumothorax. You don't get a fever 101 with pneumothorax. Of note, the patient recently returned from a vacation in Australia. Now, what's that got to do with the patient's shortness of breath? Did she pick up some weird bug in Australia? Are there weird bugs in Australia? First of all, I don't know if there are. And number two, you probably need to be an infectious disease expert to know that. And they're not going to ask you that on step 3. But if she just came back from Australia, I don't think she bicycled back from Australia. She didn't come by train. She got on a plane. And this is a United States medical license exam. She went from Australia to the United States. You ain't going to get there but by plane. All right? So she sat on a long plane ride. And even if she took a couple of stops, those stops involved sitting in the plane for at least 12 hours. So she was immobilized. So now not only do I know that she has a pulmonary embolus as my first suspicion, I got a good cause for it. Okay? Physical exam. Again, if this was CCS, I'm just going to get the vital signs here. Now she's afebrile. Blood pressure is 100/70. She has respiratory rate of 28 with splinting, which means she takes a breath and it's sort of, in the middle of the breath, she sort of has to stop because it hurts. That's just consistent with the pleuritic nature of her pain. Her heart rate is 140. So she's tachycardic and tachypnic in a pleuritic sort of way. Is that consistent with PE, pulmonary embolus? Absolutely. So right now, I'm going to just, by now I would have read the last choice and it might have said, what test do I order? And give me tests that indicate PE, pneumothorax, pneumonia, MI, pulmonary edema. I would skip right to it because I know she has a pulmonary embolus. All right? So now I'm going to read through the question just to confirm my clinical suspicion of a pulmonary embolus. If they ask me what medication, whether it was an antibiotic, or digoxin, et cetera, I'm going to look for the anticoagulant. All right? So now I'm fairly certain it's pulmonary embolus. All I'm reading the question for now is to see if there's any diagnosis that doesn't fit pulmonary embolus. Any information that doesn't fit. Head and neck exam. No oral ulcers, no nasal flaring, regular rhythm, no murmur, lungs are clear. Wow, could she be this tachypneic from a pulmonary embolus and have clear lungs? Absolutely. Remember, noise on your lung exam, it ain't from the blood vessels, it's from the airway spaces. All right? If there's constriction of the airway spaces in asthma, you hear wheezing. That's an airway problem. If you hear that rougher rhonchi, that's again problem in the airway. If the blood vessel is clotted off, you don't get any changes in the airway sounds. You'll get a maybe profound ventilation perfusion mismatch, but it's not going to make any noise. It's not going to decrease any sounds. So the lung exam, the most typical lung exam that you'll find in a patient with pulmonary embolus is a normal lung exam, just like you'll find a normal chest x-ray, as we'll find in a moment. What abnormality might I hear in a patient with a pulmonary embolus? As sort of a subcategory of a patient with pulmonary embolus, I might find that the patient has a pleural rub, especially if she has pleuritic chest pain. What does that imply has happened if a patient has a pulmonary embolus and has a rub? You know, she has splinting, let's say, on the right side, unilateral, and if I hear a rub there, she probably has had a pleural infarct. All right, it's a peripheral pulmonary embolus. It clotted off a vessel that goes to the pleura, and she's infarcted a piece of the pleura, and now she has pain and noise in that region. All right, so that's what I might hear. It's not an airway sound, it's a pleural sound. Extremities, there's no edema. I don't think she has any right-sided heart failure. But also, note what I don't see in this question. This is a patient with pulmonary edema. Excuse me, strike that. This is a patient with pulmonary embolus. All right? When you hear the abbreviation PE, it never means pulmonary edema. I'm sorry, the boards don't have abbreviations. PE means pulmonary embolus. If you hear an abbreviation for pulmonary edema, it's going to be APE, acute pulmonary edema. Don't get those confused. So if you hear me saying PE, I'm talking about pulmonary embolism. What's missing in the extremities here? I'm missing what is going to likely be the cause of her pulmonary embolus, which is what? She have a primary pulmonary embolus by sitting on that plane? Her lungs have been immobilized? No, her legs have been immobilized. She's been sitting in the plane without getting up and walking around too much. So I would expect to see or find and learn ultimately she has a deep venous thrombosis, deep meaning the deep venous system of her legs. Now, it could have made it very obvious for me by telling me that her right thigh is red and tender and swollen to twice the size of the left thigh. But they're not telling me that. So I have to stop and think, does this patient still have a pulmonary embolus? Absolutely she could have a pulmonary embolus. Not every patient with a deep venous thrombosis has a big, fat, swollen warm leg. She might have it, again, very deep, and it's not showing me any signs on the lower extremity. So this has not dissuaded me. So my differential diagnosis here, if this was a CCS, I'm thinking pulmonary embolus, and I want to think about what I'm going to do for this patient. Number one in CCS, what would you do here? I would probably give the patient oxygen. All right? Patient's tachypneic, my suspicion is a pulmonary embolus, I'll get oxygen on her right away. I might do a pulse oximetry before I put the oxygen on, and I should make this point for all the previous cases. Before we're putting on oxygen, arterial blood gas is an invasive, expensive, painful procedure. Nowadays, and for 15 years already, we can measure the oxygen saturation with a simple pulse oximeter. Now, say any time you're going to have a patient with acute shortness of breath, and you're going to put oxygen on the patient, and it's the CCS part of the exam, and pulse oximetry is something you can order on CCS, I would order it, because it takes a second or two to put on, and then you'll have a baseline oxygenation, and you'll be able to follow that number, which is so simple and non-invasive to follow as you're treating the patient with oxygen and your various therapies. So it's something I have not mentioned in the previous cases, but remember, in CCSs, pulse oximetry in any patient with short of breath is a very worthwhile thing to do. And you'll probably gain points for that, and you'll never really lose points for that, because it only takes a second or two, it's non-invasive, and it can give you some very important clinical, hard data. Pulmonary embolism, I'm going to do a pulse oximetry on CCS. I'll also do an arterial blood gas, because she sounds like she might be pretty sick, and I'll want to know how hypoxic is she. All right? In terms of the rest of the differential diagnosis, I really don't have one at this point. But in terms of teaching points, can she have a pneumonia? She has a fever. She has a cough. It's non-productive. Can patients with pneumonia have some blood-tinged sputum? Sure. Does she have anything on her lung exam that makes me think she has a pneumonia? No, she had a clear lung. So it's really low down on my list here. Okay? On the one hand, it doesn't fit quite right for bacterial pneumonia because it's non-productive, and it's non-productive. She did have a fever, but it's non-productive cough. It did happen acutely, which is typical for bacterial pneumonias. If I want to say it's an atypical pneumonia, why did it happen so acutely? The atypical pneumonias take days. And most importantly, pneumonia on the boards will give you some findings on the physical examination. Can she have bronchitis? Similarly, you're going to hear sounds on the physical examination that the airways are full of what plugs up the bronchus, mucus and phlegm, and she would have a productive cough. So again, it keeps bringing me back to the point, don't dissuade yourself with many other differential diagnoses. If the question was a single best answer, you see PE, pneumonia, bronchitis, pneumothorax, and I'll say the next choice would be congestive heart failure. You know it's PE. Find it, move on. Don't waste too much time considering what you know are the wrong answers. What's my diagnostic plan? Well, first of all, I'm going to get a pulse oximetry, I have to say. A chest x-ray in pulmonary embolus is going to be done to rule out other causes, because, again, the most common finding on a chest x-ray in pulmonary embolus is that you have a normal chest x-ray. The one chest x-ray finding you might find in PE, which is analogous to hearing a pleural rub, is you might see evidence of a pleural infarct with an opacity at the periphery. Because there's a blood clot peripherally, you infarct that area, and that pleural infarct appears as an opaque area. And that area is known as Hampton's hump. In reality, it's pretty uncommon to see that. And if you don't have that, you probably still have a pulmonary embolus if everything else is going for pulmonary embolus. Chest x-ray, as I suspected, normal. I'm going to do a CBC and SMA 20. I want to know her white count. I want to know if there's anything peculiar about her SMA 20, but that's not high on my list. Again, I really should have here that we're going to do a pulse oximetry and an ABG. CBC and SMA 20 are normal. ABG is done. What do I expect it to show? Maybe they'll tell me in the question. Maybe that'll be the basis for the question. An ABG is done. Which of the following is the most likely to be found? What will you predict the findings here? I would predict, what's her pH going to be, high or low? Acidemic or alkalemic at this stage of a PE. I would say she's probably hyperventilating. It's going to be high. She's going to have a pH of over 7.45, let's say. What's her PCO2 going to be? At this stage, I would say she's hyperventilating. It's going to be low. What would her PO2 be? It's not going to be normal. It's going to be low, maybe 60s, 70s, or maybe even lower if it's a very big PE. And I'll certainly find that she has an alveolar arterial gradient. What do I find? pH 7.50, PCO2 of 29. She's hyperventilating. Her PO2 is 70 millimeters of mercury. Doesn't sound like a terrible number, but again, she's breathing all the way, she's hyperventing all the way to a PCO2 of 29, and yet her PO2 is only 70. So you know this patient has a significant AA gradient. And this is while it's done on room air, so you get a baseline before you start giving her oxygen. And again, pulse oximetry should be in this list before the ABG. An EKG, not essential, but at this point, now that I've stabilized the patient, hopefully with some oxygen, an EKG might show me signs of right heart strain. If I have a huge pulmonary embolus, the right ventricle is contracting against an artery that has one big clot there, and the resistance is high, and I might see signs of acute right-sided heart failure on my EKG. I don't sit here, see it in this patient, all I see is a sinus tachycardia. Why did I suspect pulmonary embolus? Well, we discussed it, the long plane ride home. She had the typical presentation in terms of symptoms. She had tachycardia, fever, pleuric chest pain. She had some hemoptysis, which is not inevitable. Most patients with PE don't have hemoptysis. If she had hemoptysis, it implies that she probably had some mild pleural infarct. Chest x-ray is mostly useful to rule out other possibilities. Again, in this patient, I didn't really think that other possibilities were very likely. How do we assess the patients? Whenever I see ABG here, I would assume that I've already done a pulse oximetry to confirm her oxygen saturation. I expect a respiratory alkalosis in a PE with hypoxia. A lower extremity Doppler is going to be a very useful test. Now let's talk about, all along we've talked about our initial stabilization of this patient and all the negative findings, normal lung exam, normal chest x-ray. How will we go about establishing firmly that this patient has a pulmonary embolus? Well, the most likely etiology of a pulmonary embolus in this woman who's been sitting on this plane is that she has a deep venous thrombosis. So a quick, non-invasive test that I could do is a Doppler examination of the lower extremities, and it will show me impaired flow in a deep vein of the femoral vein, or more proximal in the pelvic veins, which you can't see on a sonogram, but it will show backup of flow to the femoral veins. And I'll know the patient has a DVT. And with all her symptoms, I know she has a PE, which I'll then go on to establish with the next step that you see on this slide. However, a Doppler alone is enough if it shows me a DVT to start treatment. And the treatment for DVT and for PE, as you know, is the same. It's anticoagulation. If the question specifically says, which test would I order to document or diagnose a pulmonary embolus, and they say Doppler examination of the lower extremities, or venogram of the lower extremities, versus a VQ scan, a ventilation perfusion scan, to document a pulmonary embolus, I want the VQ scan. If the question, on the other hand, says, which of the following tests would you order, and they list it for you because maybe they want to test if you know that's really a pulmonary embolus, they ask you, do you want to do a Doppler first? Do you want to do a chest CAT scan? Or maybe they want to trick you into other tests for DVTs. Let's say, we said Doppler, we said chest CAT scan. Do you want to do a venogram as the next step, a painful, invasive procedure? We inject dye under high pressure into a foot vein and try and fill the whole venous system of that leg and the pelvic veins. Do you want to do that before a Doppler? No. It's more invasive, more painful, more side effects. You'll start with the Doppler. Do I do a pulmonary angiogram in this patient? Pulmonary angiogram is highly invasive. We'll talk about the indications for that. I'm not going to want to do that if I have a choice of doing a Doppler. Okay? So you get a sense of which tests are appropriate as first step. Doppler is an appropriate, non-invasive first step. Does it tell you about PE? No, but it tells you the underlying cause for the PE, which is enough reason to start treatment with anticoagulation. A ventilation perfusion scan is a nuclear medicine test, not invasive, and it will demonstrate ventilation and perfusion mismatches. And with this big pulmonary embolus, you'll see one large vessel that doesn't have perfusion, whereas there's still ventilation there. Or in a patient who's very symptomatic with a pulmonary embolus, you might not see one large one, but you might see multiple mismatches, a number of small pulmonary emboli. Remember, these are emboli in the lung, not thrombi, meaning they're emboli, they're coming from someplace else. And that deep venous thrombosis is where the clot originates, might be sending showers of emboli, and you might not have one huge mismatch, but you might have a very sick patient with multiple smaller mismatches. Rarely will you need a pulmonary angiogram. When would you find a pulmonary angiogram to be the right choice? One situation would be where the ventilation perfusion scan is, it's not exactly low probability, it's not exactly high probability, it's intermediate probability. And you don't find the DVT on your Doppler. Will you put this patient on anticoagulation with an intermediate probability? Well, if the patient has a great story for PE, like this patient, then I won't. If, on the other hand, the patient does not have a great story, before I start anticoagulation, I want to make sure that the patient really needs it, and I'll do a pulmonary angiogram. Right? Pulmonary angiogram also, in case of life-threatening PE, allows you to deliver thrombolytic therapy or do an embolectomy, but those are really rare situations. By far, you'll cover 99% of the PEs on the boards with either a Doppler examination of the legs or a VQ scan. And again, you have to look for the wording of the question. To say which of the following would be sufficient to start anticoagulation, a positive Doppler or a VQ scan. Which one would be necessary to demonstrate the actual PE? VQ scan. What are the risk factors in this patient? Well, the patient, not in this situation, but in general, what will make you think of a PE in patients? If they're post-operative, especially if it's post-op for a hip where they'll be immobilized for several days. If there's any situation of venous stasis, the patient has a hypercoagulable disorder in a young woman, even without a history of having prior clots, I would want to see if she's on an oral contraceptive, which makes her prone to hypercoagulable events. If the patient is obese, that in itself is a risk factor. And if the patient has had a previous DVT, that's considered a risk factor for future DVTs because that vein has been damaged. Okay, so let's talk about the treatment plan. If this was CCS, I've documented a DVT or I've documented a pulmonary embolus. What am I going to do next? I'm going to start treating that patient. What's the appropriate treatment? Heparin. You'll type it in heparin. What will come next is, how would you like to give heparin? Is subcutaneous adequate, or do you need intravenous? Intravenous is higher risk, greater risk of bleeding, but in fact, that's what you need. Subcutaneous heparin for an acute DVT or acute PE is not sufficient therapy. It's good for prophylaxis of a DVT in a patient who's high risk, such as a patient who's post-op and immobilized, but it's not adequate once you've established that your patient has a DVT or a pulmonary embolus. We're going to give the patient oxygen, which we've already done. We're going to do Doppler studies, as we discussed. If the patient cannot tolerate anticoagulation because they just had a big ulcer bleed, or they have just had surgery within the last 12 hours, and now they have the pulmonary embolus already, then what I will do is put in an inferior vena cava interruption device. That will do nothing for the PE if it's already there. I'm going to depend on the patient's own fibrinolytic system to break down that pulmonary embolus. But what the inferior vena cava filter will accomplish is it will prevent further clots coming from the deep veins of the legs or pelvis into the lungs and causing further hypoxia and additional PEs. Remember that heparin, even when you're using heparin, it doesn't do a thing for the pulmonary embolus that's already in the lungs. That one is there. Heparin is not a thrombolytic. Heparin is an anticoagulant. It will prevent additional clots from forming in the lungs, all right? And it's not going to do anything to that DVT there. But what's going to happen is your body's own fibrinolytic system will break down the pulmonary embolus that you have there, and hopefully the heparin will prevent new clot from forming in that region. Besides the situation that I just mentioned, that anticoagulation is contraindicated, let's say you have the patient on anticoagulation. They tell you, they give you straight out, patient had a pulmonary embolus 24 hours ago, you put the patient on heparin, you made the diagnosis appropriately, and now the patient has worsening again of their pulmonary function with typical signs and symptoms, again, of a PE. You do another VQ scan. Sure enough, there's another new big pulmonary embolus. They tell you all that in the question. This question says, what do you do next? Raise the heparin? Well, first of all, if the heparin was anti-coagulating the patient adequately, adding more heparin is not the answer. How much heparin do you use, by the way? You use enough to target the partial thromboplastin time, the PTT, to 1.5 to 2.5 times control. If you have the patient well anticoagulated and they develop a recurrent PE, what you do is put in an IVC filter, because obviously anticoagulation with heparin is not enough. If, on the other hand, they give you that same situation that I just described with a recurrent PE type of scenario, and they tell you the partial thromboplastin time is 39 seconds and the patient's control is 30 seconds, that case, I will give additional heparin. If the patient has significant hemodynamic compromise, in other words, they have refractory hypoxemia despite giving them 100% oxygen, or they have so much pulmonary artery resistance, they develop acute right-sided heart failure to the point of becoming hypotensive, if the PE is that hemodynamically significant, then I'm not content to let the body's thrombolytic system work over the next few hours or day. I need to bust that clot, just like in a coronary artery, and that's when I'll use thrombolytic therapy in a pulmonary embolus. And if you use thrombolytic therapy, it does not have to be through a pulmonary angiogram. You could deliver it through an IV vein. And typically there we'll use streptokinase. Once the patient is adequately anticoagulated on heparin, the body's own fibrinolytic system is doing its job, the patient's gotten better in terms of symptoms, while on heparin, I want to get the patient off heparin and transition them to Coumadin so they could go home and maintain themselves on Coumadin as their chronic anticoagulant. How do I monitor the use of Coumadin? There I'm aiming for an INR, which is a measure of the adequacy of your effect on the pro time. I'm looking for an INR of 2 to 3. And that will be the long-term anticoagulation process. How long, you might be asked, do you use anticoagulants in the form of Coumadin once the patient is home? If the patient had a single reason to have the DVT or PE that's no longer present, such as that single long plane ride and otherwise doesn't have any risk factors for DVT or PE, then I'll usually treat Coumadin for 3 to 6 months. If the patient, on the other hand, has some other underlying reason to have PEs again in the future or DVTs in the future, such as they remain hypercoagulable for some genetic hypercoagulable disorder, or they have an underlying malignancy which makes them hypercoagulable that I can't make better. If they have consistent CHF, consistent obesity, consistent immobilization because they're bedridden with some disease, then I will use Coumadin for an indefinite period of time unless I could correct that underlying disorder. But if it's a once-only event without ongoing reasons for pulmonary emboli, 3 to 6 months with Coumadin. Otherwise, indefinite use. So to summarize, our evaluation and management of a patient with pulmonary embolus, the immediate effect is to obstruct the pulmonary blood flow in the distal lung. It results in wasted ventilation. That's what we find with the ventilation-perfusion mismatch. You get atelectasis, perhaps, but usually that's not a major component. You develop a big AA gradient, and in severe cases, you can develop right heart strain to the point of severe right ventricular failure, signs of JVD, signs of a right ventricular heave on exam, allowed P2, allowed pulmonic component of the second heart sound, and other signs and symptoms of right-sided heart failure. And we'll take a break here